Describe a complex patient case you managed from admission to discharge. What was your nursing process, and what was the outcome?
One particularly complex case I managed was a 72-year-old female patient admitted with a primary diagnosis of congestive heart failure exacerbation, compounded by uncontrolled type 2 diabetes and chronic kidney disease. The situation upon admission was critical. She presented with severe dyspnea, oxygen saturation in the low 80s on room air, plus 3-pitting edema bilaterally, and profound fatigue. My initial nursing process was immediately focused on stabilization. I administered prescribed for diuretics and nitrates, initiated supplemental oxygen, and conducted frequent respiratory and cardiovascular assessments to monitor her response. As her acute respiratory distress subsided over the first 48 hours, the broader task of managing her intertwined chronic conditions came to the forefront. My comprehensive assessment revealed significant knowledge gaps. She was inconsistent with her medication regimen and had a poor understanding of the connections between her heart failure, diabetes, and renal diet. My actions were multifaceted and involved meticulous coordination. I developed a detailed education plan, breaking down the complex information into manageable segments. I facilitated a formal consultation with the unit's dietitian to create a realistic, sodium and fluid-restricted meal plan that also considered her diabetic needs. I collaborated closely with a pharmacist to ensure she understood the purpose and timing of her numerous medications, using a pill organizer as a visual aid. Furthermore, I involved the physical therapist to slowly rebuild her activity tolerance. The entire process was documented in our electronic health record with clear, concise notes to ensure continuity across shifts and disciplines. The result was a successful and well-coordinated discharge. The patient and her daughter were able to confidently demonstrate medication administration and discuss dietary choices using the teach-back method. Most importantly, through follow-up communication, I learned she remained out of the hospital for at least 90 days post-discharge, indicating that our multidisciplinary approach and intensive education had effectively empowered her to manage her conditions at home.
What was the most significant challenge you faced in managing that patient's care, and how did you overcome it?
The most profound challenge was not the clinical complexity itself, but the patient's initial sense of hopelessness and resignation. Having been hospitalized multiple times before, she had little confidence that this admission would be any different, which manifested as passive resistance to education and discharge planning. Overcoming this required a fundamental shift from just treating her medical conditions to caring for her as a whole person. I dedicated time during my shifts to sit with her, actively listening to her fears and frustrations about her declining health. I validated her feelings, which helped build a foundation of trust. Instead of dictating a plan, I framed our discussions around her personal goals, which she identified as being able to attend her granddaughter's wedding in a few months. This became our shared objective. I connected every educational point, every medication, every dietary change, back to how it would give her the strength and stability to reach that goal. By empowering her and making her the central agent in her own care plan, her resistance melted away. She transformed from a passive recipient of care into an active participant, which was the true key to the successful long-term outcome.
Tell me about your experience with a specific piece of technology or equipment common in this unit, e.g., EHR, for pump telemetry monitoring.
My experience with electronic health record systems is both extensive and integral to my practice. I have utilized EHRs as the central hub for all clinical data management across multiple clinical settings. My proficiency extends far beyond basic data entry. I'm skilled in performing comprehensive nursing assessments within the system, developing and updating individualized care plans, and managing the entire medication administration cycle with integrated barcode scanning to ensure the 5 rights are adhered to with 0 errors. I actively use the clinical decision support alerts to screen for potential drug interactions or allergies before administering medications. Furthermore, I am adept at utilizing the EHR for interdisciplinary communication, sending secure messages to physicians, therapists, and pharmacists, and documenting these collaborations to maintain a seamless patient narrative. I was also entrusted with the role of a super user during our last system upgrade, where I provided hands-on support and training to my colleagues, helping them navigate the new interface and troubleshoot common issues, which was critical for maintaining unit-wide efficiency and morale during the transition period.
What challenges have you faced when adapting to new technology or software updates? And what is your strategy for getting up to speed?
The most significant challenge during any technological transition is the inevitable initial disruption to established workflows, which can temporarily slow down care and increase cognitive load for the entire nursing team. My strategy for overcoming this is systematic and proactive. First, I engage with any and all available training modules well before the go-live date, not just passively watching, but actively practicing in a test environment. Second, identify and build a relationship with a clinical informatics nurse or designated super users. I'm not hesitant to ask questions, believing that a few minutes of clarification prevents future errors and saves time. Third, I mentally map my most common tasks from the old system to the new one, creating a personal quick reference guide for the first few weeks. Crucially, I maintain a positive and patient mindset, understanding that the short-term frustrations are an investment in long-term gains in patient safety, data analytics, and care coordination. I view myself as an adaptable professional for whom mastering new technology is a non-negotiable part of providing modern, evidence-based nursing care.
Walk me through your experience with patient and family education. How do you ensure they understand complex health information?
My philosophy on patient and family education is that it is a continuous, dynamic process, not a single event that occurs just before discharge. My experience has taught me that effective education begins with a thorough assessment of the learner. I start by evaluating the patient's readiness to learn, their health literacy level, their cultural background, and their preferred learning style, whether they are visual, auditory, or kinesthetic learners. I then tailor my approach accordingly. For a newly diagnosed diabetic, for instance, I would use simple language to explain the disease process, employ visual aids like diagrams of the pancreas, and provide hands-on demonstration of glucose monitoring. The cornerstone of my method, however, is the consistent use of the teach-back or show-back technique. I never assume understanding based on a nod or a yes. I ask patients to explain the information back to me in their own words or to demonstrate a skill like insulin injection. This immediately reveals any gaps or misconceptions, which I can then clarify on the spot. I also provide standardized, easy-to-read written materials for reinforcement and document the entire educational process in the EHR, including the topics covered, the materials provided, and the patient's demonstrated level of understanding, ensuring all team members are aware of the progress.
What is the most common challenge you face when educating a patient or family member who is anxious or resistant to learning?
The most common and formidable challenge is the psychological barrier created by fear, anxiety, or even grief over a new diagnosis. When a person is in a state of high emotional distress, their cognitive capacity to absorb complex information is significantly diminished. In these situations, my first action is always to pivot from educating to empathizing. I consciously create a calm and private space, sit down with them, and practice active listening. I acknowledge their fear by saying something like, "It's completely understandable to feel overwhelmed by all of this." I validate their emotions without judgment. Once I sense a slight reduction in their anxiety, I then introduce education in very small, prioritized pieces. I might say, "Let's just focus on the one most important thing for today, how to use this inhaler to help you breathe easier." By building trust and rapport first, and by breaking down the monumental task of learning into tiny, manageable steps, I can often lower their defensive resistance and guide them toward a place where they become willing and active participants in their own care journey.
Beyond the mandatory requirements, what specific continuing education courses or certifications have you pursued in the last year to enhance your practice?
I am deeply committed to a philosophy of lifelong learning and actively seek out opportunities that extend beyond mandatory competencies. In the past year, I dedicated myself to obtaining my certification in medical surgical nursing, which involved a rigorous study program and a comprehensive examination. This certification has been invaluable in solidifying my advanced knowledge in caring for adult patients with a wide range of medical conditions. Simultaneously, I identified a need to enhance my skills in managing the psychological aspects of chronic illness. To that end, I enrolled in and completed a specialized online course on motivational interviewing techniques for healthcare providers. This training has equipped me with proven communication strategies to help patients navigate ambivalence and activate their own internal motivation for positive health behavior change, which has been particularly transformative in managing patients with conditions like heart failure and COPD who struggle with lifestyle modifications.
What challenges do you face in finding the time or resources for continuing education, and how do you prioritize it?
The challenge of balancing a demanding full-time clinical schedule with the pursuit of advanced education is very real. The primary obstacles are time fatigue and the financial cost of some certifications. My strategy for overcoming this is intentional integration and strategic planning. I treat my professional development not as a separate hobby, but as a core component of my nursing identity. I proactively block out small, consistent periods in my weekly schedule for studying, even if it is just 45 minutes 3 times a week, treating this time as a non-negotiable appointment. I also prioritize courses that have a direct and immediate application to my current patient population, ensuring that the investment of time pays direct dividends in the quality of care I provide. Furthermore, I actively seek out hospital-sponsored or subsidized educational opportunities first. By framing continuing education as an essential, integrated part of my professional life rather than an external add-on, I'm able to consistently make progress and stay at the forefront of clinical practice.
Describe a time you identified a knowledge gap in your own practice. What steps did you take to address it?
There was a specific situation where I was assigned to care for a patient with a chest tube connected to a digital drainage system, a device that was newer and more technologically advanced than the traditional water seal systems I was accustomed to. While I understood the fundamental principles of chest tube management, I realized my knowledge was insufficient regarding the specific alarm interpretations, troubleshooting steps, and the nuanced meaning of the digital pressure readings for this particular device. Recognizing this gap was critical for ensuring both the patient's safety and my own professional confidence. My immediate action was to be transparent with my charge nurse and inform her of my learning need. I then sought out the unit's clinical nurse specialist, who was an expert in this area. I arranged a time for her to provide a hands-on in-service tutorial for me at the bedside, where we reviewed the manufacturer's quick guide and she walked me through various simulated scenarios. I took detailed notes and asked clarifying questions until I felt fully competent. I then spent time later that week reviewing online resources and videos provided by the device manufacturer to reinforce my learning. This proactive approach not only closed my knowledge gap, but also turned a moment of uncertainty into a valuable learning opportunity.
Follow up. What challenges did you encounter while bridging that knowledge gap, and what did you learn from the process?
The initial challenge was internal, overcoming the feeling of vulnerability and the fear of being perceived as incompetent by my peers or the clinical specialist. There is a natural temptation to fake it till you make it in a high-stakes environment, but I have learned that this approach compromises patient safety. The process reinforced a fundamental lesson that self-awareness and humility to acknowledge what you don't know are hallmarks of a true professional. I learned that the most valuable resources are often the experienced colleagues and specialists within my own organization who are almost always willing to share their knowledge when approached with a genuine desire to learn. This experience solidified my belief that continuous learning is not about knowing everything, but about knowing how to find the answers and having the courage to ask the right questions, thereby transforming potential weaknesses into future strengths.
How do you typically stay current with the latest evidence-based practices and clinical guidelines in your specialty?
Staying current is a multifaceted and active process for me. I maintain an institutional subscription to the American Journal of Nursing and regularly scan table of contents for relevant articles. I also follow key professional organizations, such as the American Association of Critical Care Nurses, on social media to receive updates on new guidelines in real time. Furthermore, I am an active participant in our hospital's Shared Governance Council, where we review current evidence and discuss its potential application to our unit's policies and procedures. For instance, we recently reviewed evidence on preventing hospital-acquired pressure injuries and successfully advocated for a trial of a new silicone foam dressing for our high-risk patients. This blend of independent journal reading, engagement with professional bodies, and practical, committee-based application ensures that my practice is not only informed by the latest evidence, but also critically appraised for its relevance and feasibility in my specific clinical context.
What is the biggest challenge you find in applying new research or evidence to your daily practice on the unit?
The single biggest challenge is navigating the no-do gap, the significant lag time between the publication of compelling evidence and its widespread adoption into the entrenched culture and routines of a busy clinical unit. There is often inertia, skepticism, or "this is how we've always done it" mentality that can be difficult to overcome. My strategy for addressing this is to lead through influence and data. When I identify a practice that could be improved, I don't just present a problem. I come prepared with a concise summary of the evidence, a proposed practice change, and a plan for a small-scale trial. For example, when advocating for a new turning schedule, I presented the data on reduced pressure injury rates and also volunteered to help create a simple tracking tool for the whiteboard. By making it easier for my colleagues to adopt the new practice and by demonstrating its benefits through clear data, I can help bridge that gap and foster a unit culture that is more agile and responsive to evidence.
Tell me about a time you had to advocate for a patient with a physician or another member of the healthcare team.
The situation involved an elderly post-operative hip replacement patient who was showing subtle but concerning signs of delirium. While he was not overtly agitated, he was becoming increasingly confused and lethargic during the night. The day team physician attributed this to sundowning and was hesitant to order further workup. However, my task, based on my prolonged contact with a patient, was to ensure that reversible medical causes were not overlooked. I knew I needed to advocate for him in a respectful but persuasive manner. My action was to prepare a clear, data-driven case using the SBAR, Situation Background Assessment Recommendation Framework. I contacted the covering hospitalist. I outlined the situation, the patient's acute change in mental status. I provided the background, his surgical history, and baseline cognitive function per his daughter. I presented my assessment, including vital signs, a current confusion assessment method (CM) score, and my concern for potential causes like infection or electrolyte imbalance. Finally, I made a specific recommendation to order a urinalysis, a basic metabolic panel, and a complete blood count to rule out common contributors. I framed the conversation collaboratively, stating, "I'm concerned there might be an underlying medical issue we're missing." The physician appreciated the structured communication and the concrete clinical data I provided and agreed to the tests. The result was that the patient's urinalysis came back positive for a significant urinary tract infection. He was promptly started on antibiotics, and his mental status dramatically improved over the next 24 hours, preventing a potential escalation to a more severe septic state.
What are the common challenges you face when advocating for a patient, and how do you ensure your voice is heard respectfully?
The most common challenges are hierarchical structures, time pressures on all team members, and potential for miscommunication. To ensure my voice is heard respectfully, I rely on a foundation of preparation and professional demeanor. I always ensure my advocacy is rooted in objective data and direct observation, not emotion or assumption. Using a structured tool like SBAR forces clarity and professionalism into the conversation. I also carefully choose my timing and setting, opting for a private conversation or a dedicated phone call, rather than a hallway interruption when possible. Most importantly, I enter every such conversation with a presupposition that we share a common goal, the patient's best interest. By using I statements, "I'm concerned," asking open-ended questions, "what are your thoughts on," and actively listening to the other provider's perspective, I foster a collaborative rather than confrontational dialogue. This approach demonstrates respect for their expertise while firmly establishing my vital role as the patient's bedside advocate.
Describe your experience collaborating with interdisciplinary team members like physical therapists, social workers, or dietitians.
My experience with interdisciplinary collaboration is that it is the engine of holistic patient care. I view my role as the central coordinator, facilitating the flow of information between all specialists. For instance, when managing a patient following a stroke, my collaboration with the physical therapist is constant and bidirectional. I communicate my observations from the morning care, such as the patient's ability to bear weight during a transfer or their level of fatigue, which allows the PT to tailor the afternoon therapy session for maximum benefit and safety. Simultaneously, I work closely with the speech-language pathologist regarding the patient's swallowing status, ensuring I provide the correct diet textures and monitor for aspiration. Concurrently, I partner with the social worker, providing them with clinical updates on the patient's progress, which is essential for them to arrange appropriate discharge services, such as home health or rehabilitation facility placement. This is not a series of isolated interactions. It is an integrated web of communication, often formalized through daily huddles or entries in a shared EHR, ensuring that every team member is aligned and working towards a unified patient-centered discharge plan.
What challenges do you typically face in ensuring clear and effective communication within a large, interdisciplinary team?
The primary challenge in a large team is the risk of information silos, where each discipline documents thoroughly in their own section of the chart but fails to synthesize a shared mental model of the patient's overall status and goals. Different terminologies and priorities can also lead to misunderstandings. My strategy to overcome this is twofold. First, I am a strong proponent of bedside rounding and interdisciplinary team meetings, where all parties can discuss the plan of care simultaneously. Second, I practice closed-loop communication. If a physiotherapist recommends a patient dangle at the bedside twice before lunch, I not only document it but also verbally confirm my understanding with them, and then inform the nursing assistant who will be executing the task. I make a point of reading the notes from social work, respiratory therapy, and other disciplines to get a complete picture. By taking personal responsibility for both disseminating and synthesizing information, I act as a crucial link that helps bind the diverse expertise of the team into a coherent and effective whole.
Describe the most demanding assignment or patient load you have handled. How did you organize your shift to provide safe care?
The most demanding assignment I have managed was on a short-staffed evening shift where I was responsible for 6 patients, 2 of whom were highly acute. The situation included one patient fresh from the PACU following major abdominal surgery requiring frequent neurovascular checks and pain management, another with sepsis on a titrated vasopressor drip requiring strict hemodynamic monitoring, and 4 other patients with complex medical needs including diabetes and cardiac issues. The task was monumental, to provide safe, compassionate, and comprehensive care to all 6 without a single error or omission. My first action was to conduct a rapid but thorough round of introduction to all 6 patients, visually assessing each and quickly prioritizing their immediate needs using a mental ABC, airway, breathing, circulation framework. I then created a highly structured but flexible plan for the shift, clustering care for patients in adjacent rooms to minimize travel time. I delegated specific, appropriate tasks like vital signs, hygiene, and ambulation to the nursing assistant, providing them with a clear written list and establishing check-in times. I communicated transparently with the charge nurse about the high acuity of my assignment, and we agreed she would take one of my more stable patients if her load lightened. I utilized the EHR to set timely reminders for critical interventions like antibiotic administration and pain reassessments. Throughout the shift, I constantly reprioritized, understanding that a new emergency could arise at any moment. The result was that all patients received their essential medications on time, their conditions were monitored closely, and their emergent needs were met. While it was an intensely challenging shift, I completed it with all documentation accurate and, most importantly, without a single adverse patient event, which was a testament to rigorous organization, constant situational awareness, and effective team communication.
What are the most significant challenges you face in maintaining composure and delivering quality care during exceptionally high-stress shifts?
The most significant challenges are the physiological and psychological toll of sustained stress, which can lead to mental fatigue, rushed decisions, and a decline in compassionate communication. My strategy for maintaining composure is rooted in mindfulness and deliberate practice. I consciously employ tactical breathing techniques, inhaling for 4 counts, holding for 4, and exhaling for 6 during brief moments, such as when I am washing my hands between rooms. This helps to lower my heart rate and reset my focus. I also practice compassionate grounding, making a point to make eye contact and share a brief human connection with each patient, even if it's just for 10 seconds. This reminds me of the purpose behind the chaos. I'm also a firm believer in closed-loop communication with my colleagues. Knowing we are a team and verbally confirming tasks reduces cognitive load and prevents errors. Finally, I'm not afraid to verbally acknowledge the stress with my teammates in a brief moment of shared commiseration, which fosters a supportive environment. After such a shift, I engage in a deliberate decompression ritual to process the events and prevent burnout, ensuring I am mentally prepared for the next challenge.
Tell me about a significant change in policy or procedure on a unit where you have worked. How did you adapt your practice?
A significant change occurred when our hospital transitioned to a new, facility-wide fall prevention program that introduced a new, more complex risk assessment tool and mandated a new set of interventions for high-risk patients, including hourly rounding with a specific protocol. The situation initially caused some frustration on the unit, as it was perceived as adding more documentation and tasks to an already heavy workload. The task for me, however, was to understand the evidence behind this change and integrate it seamlessly into my daily practice. My first action was to attend the mandatory in-service with an open mind, actively asking questions about the data supporting the new protocol. I learned that the hospital's baseline fall rate had been unacceptably high, and that this new bundle of interventions had a strong evidence base for reducing falls by over 30%. This understanding transformed my perspective from one of resistance to one of ownership. I then took the initiative to create a personal checklist that incorporated the new hourly rounding requirements into my existing workflow. I also volunteered to be a peer mentor for 2 colleagues who were struggling with a change, helping them see the clinical rationale and sharing my time-saving tips. By embracing the change proactively and focusing on the positive patient outcome it was designed to achieve, I was able to adapt my practice effectively and even contribute to a positive cultural shift on the unit, which ultimately led to a measurable decrease in our patient fall rates within 6 months.
What challenges do you generally face when adapting to major institutional changes, and how do you work through them?
The universal challenges are the discomfort of moving out of a well-established comfort zone, the initial drop in efficiency, and the collective morale dip that can occur when a team is faced with a top-down mandate. I work through these challenges by first consciously reframing the change in my own mind. I view it not as a criticism of past practice, but as an opportunity for systemic improvement. I seek to understand the why behind the change, as knowing the underlying evidence or the strategic goal makes the temporary inconvenience feel purposeful. I then focus on what I can control, my own attitude and my approach to learning. I break the new process down into small, learnable steps and celebrate small victories in mastery. Furthermore, I actively avoid participating in negative break-room gossip about the change and instead try to engage in solution-oriented conversations with my peers. By adopting a flexible, growth-oriented mindset and supporting my colleagues through the transition, I'm able to not just adapt to change, but to become an agent who helps facilitate a smoother adaptation for the entire team.